Our ASH 2015 coverage continues. Thomas Baldrick joined now by Dr. Amir Fathi from the Massachusetts General Hospital. Thank you, sir, for coming by.
Thank you for having me.
A Miami Dolphins fan in Boston, go figure.
That's right. I've had a long time of suffering, but hopefully it will improve soon.
Okay, well, hopefully the next few minutes here you
That's
won't
right,
suffer.
that's right.
All right, so you're combining 33A with a hypomethylating agent in Frontline Unfit AML. Why choose to do this, sir?
So the traditional upfront approach of acute myeloid leukemia in the fit younger patient is aggressive cytotoxic chemotherapy and has been sort of the main approach for those patients for almost 3 decades. In recent years, there has been a development of hypomethylating therapy, which are generally better tolerated, milder, outpatient delivered medications that are given to patients who are perhaps less fit, older, who can not tolerate more aggressive approaches. These therapies, in addition to being well tolerated, also have some improvement in outcomes, some improvement in blood counts related to them, but response and remission rate has been traditionally low with these modalities. And I think many folks want to try and improve upon hypomethylating therapy in terms of response in patients who perhaps are not fit for more aggressive chemotherapies that do provide more robust response rates. And in light of that, this particular trial, or a key arm of this particular phase 1 trial, seeks to combine an antibody-drug conjugate named vadatuximab talarine, also known as SGN-CD33A, also known as 33A, which is a targeted cytotoxic approach to leukemia in combination with hypomethylating therapy to see whether we can improve upon the historical rates of response in patients who receive hypomethylating therapy alone.
So you've got a valid goal here. How did you go about design for this?
So I think in general, Seattle Genetics and the folks that helped them, including individuals and academics, sought to develop a way whereby the drug could be administered concurrently with hypomethylating therapy. Hypomethylating therapy mainly consists of 2 drugs, 5-azacitidine and decitabine. Decitabine is given over a period of 5 days, once daily for 5 days. Azacitidine is typically given over 7 days, once daily for 7 days. And 28-day cycles, the first 5 or 7 days of which is treatment, then recur over and over again until there is response assessment and so on and so forth. The addition of vadatuximab talarine, or 33A, is given on the last day of treatment. So for example, if we're giving azacitidine, we would give 7 days of azacitidine. On the last day, the 7th day, we give the antibody-drug conjugate following the last dose of azacitidine. And then similarly, we wait for the additional 21 days of the 28-day cycle to pass, and we can give up to 4 cycles of this type of treatment. And thereafter, if the patient does have some sort of response during that first part of treatment, we can continue on with treatment until the patient progresses or relapses. So it's a very nicely designed study, in my opinion, where you potentially give a very effective cytotoxic chemotherapy, which is targeted to 33, which is a protein on the surface of leukemia cells, in addition to hypomethylating therapy, which can take time to work. So the combination of the 2, I think, has led to some nice responses for the small cohort of patients we've studied today.
What kind of difference did you find?
This is a cohort of a phase 1 study, so there is no comparator arm, so there is no established difference. But what we did find is a specific response rate, or composite remission rate, that hovers in the 50 to 60% range, which is much higher than the historical numbers associated with hypomethylating therapy alone, which generally range in the 20% to 30% range. So it is higher than historical numbers. What ultimately needs to happen are additional advanced phase studies which seek to compare hypomethylating therapy plus 33A randomized to that arm versus hypomethylating therapy alone. That would be a phase 3 randomized study which compares those 2 arms, and that is planned, I believe, by Seattle Genetics in the very near future.
Okay. Overall, your assessment of the results?
I personally, I'm biased. I'm an investigator on the study, but I do believe that this is very exciting, very intriguing. to a large number of patients, mainly, so that what's important to note that acute myeloid leukemia is a disease of older patients. The average age is 67, so there's a good number of patients that may not be eligible for aggressive induction chemotherapy and who have had very minimal options over the course of the last several decades. If we are able to improve their response rate with this type of treatment, I think we've made significant advances. I think subsequent trials will hopefully allow us to establish that.
Well said, sir. Thank you.
All right,
Appreciate it.
thank you. No problem.